line with us. This is a great pleasure, and let's see how he feels and how he comments about this a little controversial topic that used to be not so important, we thought, but turns out is more complicated than ever imagined in some ways. First of all, the aortic stenosis has a lot of hemodynamic sequela in the coronary perfusion pressure and otherwise, and affects the function of the coronary arteries, and obviously it's also further affected by coronary artery disease. Ultimately, the coronary flow reserve and all the related indices are affected unfavorably. So what happened with coronary disease in patients with TAVR? I mean, initially, there seemed to be a lot of CAD, and lately, there doesn't seem to be so much. So first understand that in the initial years of TAVR, the patients were much higher risk in general. So to a certain degree, they're also much older. You remember it were the inoperables and the very high risk and the medium risk and all that. So expectedly, we believe those patients had a lot of CAD. At the same time, the definition, at the same time, because it was the initial trials, nobody paid that much attention in how do you define CAD in those studies. So the definition was also very permissive. So if you have CAD, some studies require even non-obstructive CAD to be marked as CAD. So there was a lot of people, there was a lot of, I would say, noise in the data field point of view. So over the time, and as we go into low risk, the patients are becoming milder comorbidities and expectedly lower CAD. At the same time, the definition became much stricter. In the past few years, the definition is essentially previous CABG, previous PCI, or any disease over 50%. So really, I'm talking about obstructive CAD, not any coronary disease. That's why the numbers seem to be plummeting recently. So let's understand that part. So on face value, one can say in the initial part how people did with CAD or not CAD. And you can see in this analysis of several studies, doesn't seem to pay a lot of difference, maybe a little bit worse, but not so important. But if you go into important CAD, which is, I think, what everybody has really in mind when talking about TAVR and CAD, you can see that a reasonably complex, not very complex, syntax score over 22, all of a sudden, you do have a significant interaction and a higher mortality, as also expected. So the above result, the green, was a little bit unexpected. But I think when you look at it more carefully, that's why I say the way the data are collected and the way the definitions of the data field are entered are very important in understanding what we're talking about. So talking about CAD that produces some high syntax score, mediumly high syntax score, then that becomes prognostically important, something to talk about. And the assessment of CAD is also a little variable in the European guidelines as a class 1 for coronary angiography. In the American guidelines, it's a bit more permissive. And if there is a CT angiography that we use for TAVI, at the same time, we have reasonable imaging of the coronary arteries, that's enough. In fact, I know that a major medical center in New York very rarely performs coronary angiography, and somehow they claim that their CT rules out CAD very frequently at a very high level of certainty. Somehow our CT scanners are not so optimized most of the time because of the differences in phases. But again, probably what they're evaluating is the proximal segments, and if they're happy with those, then they forego the distal segment and detailed analysis of coronary disease. We don't do that, but in general, that is what is available out there. The FFR and the IFR and all that have been a little bit flawed. There are some limitations. It's not a very, I would say, well-accepted consensus, but personally I do use IFR for intermediate lesions in the patients in order to make a decision. Make a decision, it's important to also understand when I make a decision, are you going to go for TAVI, are you going to have a PCI before TAVI, or you're going to have a PCI after TAVI? That's an ongoing debate a little bit. And there's disadvantages and advantages. PCI before TAVI is a more of an easy procedure. Why? Because you have free access to the coronaries, you don't have a metal cage to worry about, and all that. At the same time, you have a disadvantage that the patient has significant aortic stenosis, and when I practice that pathway, a lot of times I end up having to do a bridge BAV if there's a very complex procedure to be done, such a rotablator or something like that, a left main. A PCI after TAVI, you no longer have the aortic stenosis, but you have the drawback of how you're going to engage practically the coronary arteries and all that in reasonably good, I would say, technical ability to perform a complex procedure, sometimes required. So to an initial result, some of these matters, sometimes you have to get an initial result from somewhere, perhaps the data limited or the quality of the study limited, but still makes news. And then you have to react to it, and then the subject starts getting discussed. So what happened also here, we have a study here that indicated that the orange field, which is the minority of patients, seem to have lower event rates. So the minority of the patients were those who had a PCI during TAVI or after TAVI, essentially. So all of a sudden, they say, you know what? Why are those having low? Well, it's really bad if you do PCI after TAVI. That's how this came about in the news and in the discussion. And of course, what we understand about that is, first of all, you have to be cognizant that there's a patient selection here. So the people who have the PCI at the time of the TAVI seem to be selected for it. So could they have a very simple lesion or an overall favorable profile? Perhaps. And at any rate, we have to figure out better in a randomized trial. That's why it's very important, but at the same time, it worked to bring this whole subject into the news and into the discussion scientific community, because we had an unexpected result, that the stage PCI somehow did it better. But if you do PCI before the TAVI, you did worse, although the majority seemed to be in the blue pie, 65%. So talking about now PCI after TAVI a little bit more closely, because that's what we seem to be doing or seem to be advocating or supporting based on this study, you have to also look very realistically of how can you really engage the coronary arteries. Before TAVI, that's not a problem. You're hitting 100%. After TAVI, everybody says no problem, which means 83% for the left coronary artery and 64% for the right coronary artery. If you accept semi-selective cannulation, which might be okay for diagnostic angiogram of a medium importance, but not for PCI, or you have to figure out with guide extensions and all that, more involving procedures, you can reach about 96%. And you have about 4 or 5% of people who are very difficult to engage the coronary arteries, let alone to engage them with a level of ability to perform a PCI. So we have to be a little careful there, because there's certain, this is not 0.1%. You can see the 5%, and if someone is less comfortable or less skilled in the coronary intervention field, we're talking about between 10% for the left coronary artery and 30% for the right coronary artery unable to access that. So we have a practical consideration. So let's see what this comes about. It comes about from the fact that the valve may be malaligned with the coronary artery. So although in the native sinuses you go in the coronaries, in the new neosinus, you can't go into the coronaries because you have some material in front of there, either the valve, the cage, or the leaflet, or any of those. And you can see that the valve choice and the valve type, and in fact there's a lot of evolution in the evolute valve that seem to have more of a problem of that in order to resolve that. And you see that we have the newer additions of the FX Plus with some cells that are bigger in the areas of the coronary artery. So the manufacturers of the valves acknowledge this as a significant problem, and they actively have taken steps to help out the situation. And we will continue to working on it. Why? Because everybody agrees it is important. So then we have a trial now, which of course it's a I would say, a result of the fact that we had a good this surprise retrospective study. So in Canada, about a couple of hundred patients with symptomatic AS and significant CAD, they were randomly assigned to have a PCI or don't have a PCI prior to the TAVI. And you can see that at 12 months, there was essentially not a big difference between the two, let alone that the no PCI seemed to have less bleeding. So all of a sudden, you have a broader situation here, saying, you know what, what's happening in these Canadian sites? Well, why you even have to bother with, and if you don't bother with doing a PCI, then secondarily, why don't you even bother defining the coronary arteries? So you see, one thing leads to another. Anyhow, PCI in patients undergoing TAVI was investigated in Notion 3 trial a little bit more comprehensively from the Scandinavian point of view, and we can see there's conservative management plus TAVI and PCI plus TAVI. Let's see what happened at 1 year in this larger group, and you can see they're now double the size of the activation, about 500 people. Everybody picks up and says, you know what, the studies are like one shows one way, shows the other way. I don't agree at all. The studies are extremely consistent. If you look at 1 year result, which is the time point of assessment by the activation trial, this study also shows no difference. So the impact of treating CAD in patients with TAVI is a longer-term matter. It's not a 1 year matter. This study went out to 5 years, and you can see that although at 1 year things are looking good, exactly what activation did, showed in Canada as well, then beyond 1 year, you start having the problems. So the studies are actually quite consistent, if not identical. It's just that this study has just longer follow-up, and the differences emerged. These are the different secondary outcomes of death from any cause and myocardial infarction and urgent revascularization, again indicating that these patients were having non-QMI and related PCIs for the most part. These were the type of events that were not really deaths. That's a good explanation. Then we had another study that said, you know what, these guys are crazy. What are we doing the PCI and the TAVI? Just send the patients for a bypass and a new valve. Well, how about that? Why do you need to muck around with the PCI before TAVI, after TAVI, during TAVI, cross a valve, don't cross a valve? Why don't we just send it to bypass? Seems to, at least on the decision-making point of the clinical cardiologist, that seems to be a simpler decision. Instead of having to continuously discuss with the interventionalist, to send to the surgeons, they deal with it, and let's see how they dealt with that. About 150 to 160 patients per group. And actually, they did a far-guided PCI to even further, I would say, evaluate the situation. And let's see what happens with that. And they went ahead. And interestingly enough, the study had the important messages that the Data Safety Monitoring Board stopped the study prematurely because things are really emerging as very different between the two arms. So are we in front of something unexpected? And indeed, it was presented in the PCR and so later on published. And here, you see the result was staggeringly different in a completely unexpected way. The easy winner, the bypass plus AVR, was a big loser from in-hospital level all the way to 1 year. with an event rate of 23% versus only 4% in the TAVI plus FFR-guided PCI group. That included a staggering difference in mortality of 12% versus 1%. So one can deduce, one, perhaps the Canadians are no good in doing any bypass, which I hardly believe, or we have to really seriously evaluate all these shortcut decisions that in our mind think to be easy ones, and why not, versus to completely test exactly what may be happening in those patients. Be careful in the combined AVR CABG situations. And this is the outcomes after 1 year. It's mostly death and cardiovascular death that drove these results. And on the secondary outcomes, there was a lot of atrial fibrillation and, of course, repeat thoracotomy and bleeding with bypass. That, I would say, is expected. The unexpected was the death. And the strokes and the MIs and all that, they weren't really that different. So somehow patients didn't fare well because of other reasons, perhaps complications of surgery of some sort, and we're going to learn more about this study. But nonetheless, CABG plus TAVR inferior to PCI plus TAVI based on this randomized trial, and we're waiting for perhaps the next one to see if they can possibly refute the situation. And this is another example that we have. It takes now complete revascularization versus medical therapy. Clearly, these guys are favoring to do things after the TAVI, and particularly actually asking the TAVI with a balloon expandable valve in order to alleviate any concern that you might not be able to cross the coronaries. Let's see how this comes about, and I think I'll be interested to see that next year, in a few years, whatever. In the meantime, the guidelines are telling us that to consider PCI with 70% or more stenosis, and the American guidelines are a little bit more strict. They're indicating you have to pay attention in the left main, in the proximal LAD, in the proximal vessels, and PCI before TAVI gets a plug as a more reasonable approach, although it is a two-way indication. In patients with a low risk for surgery, then the bypass and plus CABG is reasonable, but this is, of course, 5 years ago and 5 years before. 4 years before the Canadian study I indicated to you that is perhaps expected to question this statement on the next guideline revision. Thank you very much for your attention in this session.
Thank you, George, as always, very informative. So TCW is the name to remember. Next time we deal with some argument with the cardiac surgeon and the heart team. Greg.
George, this was a great analysis, indeed, superb. One of the main reasons, actually, we have been deciding for surgery versus, TAVI has been the coexistence of coronary artery disease. And this analysis really, it tells the different thing.
Right.
And one more thing I liked is what you stated without analyzing, that you do use the IFR in assessing the severity of the stenosis. In all the studies, NOSON 3 and the others, they use FFR, which might be wrong because it's a full cycle versus diastolic, right, which is the flow. And in aortic stenosis, the full cycle might not be very accurate. So I really enjoyed that this was a great analysis.
Yeah, the FFR, but also concerned from a practical point of view, how some patients with AS might not tolerate the infusion. Sometimes you end up giving the low dose. You have a little bit of resistance. Oh, I would have resistance to go to the high dose. Yes. And those very often actually stemmed actually from the era of several years ago, then a lot of these people had a lot of lung disease, but that
and it's physiologically more accurate, actually.
A little simpler, and at the end of the day also a little bit accurate. Yeah.
So my take, George, is maybe you are not penalized when you are dealing with TAVI and CAD in older ages, but in the younger, as you go in the younger group, you have to be really meticulous in treating coronary artery disease, right?
That's right. You have to. I think that the meticulous is a key word here. Don't rush into fixing the valve just because that's a referral for. Just to go through the complete evaluation and let's prioritize the goals and use the stages. And I think it's an advantage of PCI. One can say it's a disadvantage because you cannot fix everything at the same time. But at the same time, on the other hand, is you fix things one by one. They're well tolerated, and you can see what impact it really has on the patients. Or, you truncate the procedures, less die, less hemodynamic, less hospital stay, shorter hospital stays. And what's the big deal of fixing as you know, the way the schedules of the TAVRs go anywhere, you never get called by a TAVR and you got to have it within a week. It usually takes a few months. So in some cases takes 6 weeks versus 3 months. I don't think that's a big difference in order to get things regimented and well planned.
And according to this data and the guidelines, you should try to do the PCI before. But as we discussed yesterday, there are certain situations that you need to do it afterwards. For instance, if you're planning to do a rotablator in the left main or in the LAD, and maybe you should have your valve fixed before, right?
No, I never do those really. I just do a BAV with a 18 or 20 balloon before, like an incomplete BAV to get you through the procedure. We don't overachieve now to have like a gradient of 0 or something, but if you cut the gradient by half immediately before the procedure, you successfully go through the procedure really. In extreme cases, you have to put an impeller through the new valve. I guess you can, but through the valvuloplastid valve you can, but I think this is a rarity. Have a comment? Yes, Dr.
Yes. In last September, we saw in New England the Senorita trial from England with a population similar to our TAVI patients. And in 5 years, the conservative arm was the same advantage with the PCI arm, and even in non-STEMI patients, not in chronic stable disease. You have any comment about this in your talk?
Yes, the comment is that, as I indicated, we pay attention to left main and the significant proximal disease. So I have no doubt that there are lesions in the obtuse marginals and the diagonals or the distal LAD, and those contribute to a syntax score. Maybe they were part of some NSTEMI, quite frankly. They could be culprits or targeted in the Senorita. But I think here we're really dealing about the proximal disease, and I think that is the difference. I mean, we're not going to go after an AV continuation or a PDA or something like that in a severe AS patients. But a proximal RCA, a proximal AD, proximal circle major ramus or something, it's, might as well not have that headache afterwards and clear it out before.
Okay, good. Arik, do you have a comment on that?
Hi guys. That was a phenomenal talk, George, Before everything, I'd like to excuse my leave yesterday because we had a missile attack and alarm, so I had to run to the shelter. I hope it won't happen again now. Anyhow, it was a phenomenal talk, but studies in one thing and your common practice is something sometimes else. And I think that I'm tired a little bit of saying again and again what I'm used to say, the patient-tailored therapy. I think that 85 years old lady with coronary artery disease and the tight aortic stenosis, yes, I can ignore the existence of coronary artery disease at first stage, and then later on, whether she's symptomatic or not, to treat it through the struts of the implanted valve, etc. However, I think that 65, 70 years old, and I want to remind you that the majority of patients in the United States of 65 years old and older are going to TAVR. So a 65 years old patient with coronary artery disease, I think that I can afford myself this task and do coronary angiography before, and if it's a proximal LAD or proximal SIC, you know, at the same time, treat it and then go to TAVR. So I think there is no good answer for that. I think it is patient-tailored therapy, but I think the data is pretty robust and we should not ignore it. But thanks again, it was an outstanding talk, George, really.
Yeah. Thank you, Arik, and all the best through all the troubles in your areas.
Thank you.
No, George, thank you, and maybe we will proceed to the next talk is from Roxana Mehran.